Now let's take a look at some of the examples. For Dandy Walker, malformation, again, recall the pathology, ballooning out of the fourth ventricle because of a developmental anomaly. The ballooning of the fourth ventricle gives you a high position of the torcula or confluence of sinuses here. You have hypoplasia of the vermis, and you have an enlarged posterior fossa. In the X-ray image, you see the ballooning of the fourth ventricle. Note that compared to the megacisterna magna, which may have vessels running through it because this is a subarachnoid space, this lesion does not have traversing veins because it does not communicate to the subarachnoid space. When you have elements of the Dandy Walker, when you have an element of Vermian hypoplasia, but your posterior fossa is normal in size, it's called the Dandy Walker variant, or more properly termed the Vermian hypoplasia. Another condition in this spectrum is the Blake pouch cyst, which may be hard to delineate compared to the Dandy Walker malformation. The difference is that in Blake pouch cyst, this cyst comprises of ependymal lining with ependyma. And recall that for Dandy Walker, the cyst would have a dual lining, which is pia and ependyma. So in Blake pouch cyst, you also have an increase in the tegmento-Vermian angle. However, this increase in the tegmento-Vermian angle is caused by a malposition or an elevation and rotation of the vermis. But when you scroll and take a look at the volume of the vermis will be normal in size or normal in volume. On axial image, you see this keyhole sign. This is the ventricle, and that is the cyst being formed. Lastly, for megacisterna magna, you have a prominent CSF space, the posterior fossa. You may see vessels or veins running through that cystic space, which will give you a clue that it is not a Dandy Walker or not a true cyst. Also, in megacisterna magna, since it is somewhat often just a normal variant, you will not see any supratentorial abnormalities in the same way you would expect from Dandy Walker.